Hello everyone, I am Padma Bhavani. Welcome to the Whiteboard Learning app. Today actually welcome to the Telangana Aspirants Pharmacist Grade 2 coaching classes from Whiteboard. Okay, as we all know that the notification has been released, and also we are having only from today onwards hardly 45 days, and so actually from today onwards if we start preparing for the examination, we have very short span of time. That's why you have to prepare the classes in topics in such a way that the overall concept has to be registered in your minds, and because almost the questions will be like the basic level and also very overall concept. Questions will be from the overall concept only. Okay, that's why you should know the classifications, examples, structural examples, uses, adverse effects, etc., etc. And also you have to prepare for the classes or for the exam in such a way that first you pick the important topics, important subjects and important topics, prioritize your topics, okay, and prioritize the concepts from the topics itself. Okay, so from today onwards, if you prioritize the topics and if you prepare for the classes, okay, then it will be very easy for you to crack the pharmacist grade 2 examination. So as part of our coaching classes from the Whiteboard, today I am going to discuss about a very important topic. Okay, if you take the previous question papers also, and considering the important questions and important topics and the number of questions repeated from that topic, we have selected this anti-tubercular agents. Okay, today we will see I will not take much of the time, but I will give you much of the information from this topic. Okay, so the overall concept, the aim of today's presentation is to give you as much as information, okay, maximum information in a minimum time. Okay, so let us move into the topic, anti-tubercular agents. Okay, so if you see the contents today, overall I am going to cover the introduction of the TB and anti-tubercular drugs classification, okay, mechanism of action of different drugs, their structures, because the basic structures are there, some of the basic structures are there, and their uses and some important adverse effects. Okay, so if you see what is a TB, tuberculosis. Tuberculosis is a bacterial infection caused by acid. Okay, it's a bacterial infection. So caused by acid-fast bacilli. So each and every point is a bit here. Okay, so it is from Mycobacterium tuberculosis. The nature is acid-fast bacilli, and this is a bacterial infection. Okay, so it affects the maximum lungs, not only lungs, other parts of the body also, like brain TB is there, bone TB is there. Okay, different parts it will affect. The main organ is also lungs. Okay, so affected organs are lungs, and you all know that the symptoms are cough with sputum. Okay, and it spreads through the air when infected people cough, sneeze or spit. So this is the mode of transmission. So okay, this bacteria will transmit it through the air from the person who is coughing and sneezing or spitting. So this is the basic tuberculosis definition, symptoms and causative organism. Causative organism is a acid-fast bacilli, that is Mycobacterium tuberculosis. Now treatment regimen, as we all know, chemical drug, chemotherapy. Okay, so we will give the drug medication. So there is one concept called DOTS. What is DOTS? Direct observed treatment. Okay, direct observed treatment short course. DOTS is direct observed treatment short course. It is nothing but the in presence of the concerned the person who has been infected, he will take the medication in presence of there will be a direct observation of the patient. The patient will swallow the tablet or the drugs in presence of designated person. Okay. So, a healthcare worker or other designated person observes a TB patient taking the each dose of their prescribed medication. So, that is directly observed treatment. Okay. So, that is DOTS, direct observed treatment short course. Okay. So, there is a chance of asking because this is a program initiated by the government, and this will be taken care by the healthcare workers and other designated persons. Okay. So, that is why there is some concern about this DOTS. And now we will see actually what is the treatment, what are the different drugs we will use for the treatment of this tuberculosis disease. So, there are two types, first line drugs and second line drugs. First line drugs, as we all know, these are least toxic and these are most effective. Okay, these are most effective and least toxic. So, what are the drugs? RIPES, rifampicin, isoniazid, pyrazinamide, ethambutol, streptomycin. Okay. So, these are first line drugs. First line drugs are nothing but these are having some least toxicity and these are very effective drugs. These are rifampicin, RIPES, rifampicin, isoniazid, pyrazinamide, ethambutol and streptomycin. This is just a mnemonics how to memorize, because there will be a chance of asking the example which of the following is a first line drug for the treatment of tuberculosis. All the second line drugs will be given and one drug from the first line drugs will be given. So, that first line drugs you have to memorize, that will be you to memorize in this way: RIPES, that is rifampicin, which is an antibiotic, isoniazid, pyrazinamide, ethambutol and also streptomycin. This is amino antibiotic again. Okay. So, next we will see the second line drugs. What are second line drugs? These are agents usually, you just observe the difference between first line drugs and second line drugs. So, these are less effective, more expensive and higher instance of adverse effects. Second line drugs will be having higher adverse effects. Okay, and these are less effective and more expensive. But these agents are used, but these are used in case of multiple drug resistant TB. Okay, retreatment or intolerance of first line drugs. So, some patients are very intolerant towards first line drugs. Those patients who are having the intolerance towards first line drugs, they will be given the second line drugs. Okay. So, and also resistance, in case of resistance, this second line drugs will be very much effective. And what are different second line drugs? If you see, PEC, okay, para amino salicylic acid, that is PAS, para amino salicylic acid, ethionamide, cycloserine, para amino salicylic acid, ethionamide and cycloserine, that is PEC. Next, fluoxetins, you see if it's here all sins, okay, of fluoxetine, ciprofloxacin, amikacin, kanamycin, varenicline, capreomycin. Okay. First line drugs are RIPES, second line drugs are PEC and all sins of fluoxetine, ciprofloxacin, amikacin, kanamycin, varenicline and capreomycin. These are the overall first line drugs and second line drugs that are used for the treatment of tuberculosis. So, now we have learnt about drugs, what is TB, causative agent, what are the classification, okay, drugs examples. Now, we will move into the another kind of classification, okay, standard drugs and reserved drugs. So, this is another way of classification, standard drugs and reserved drugs. And these are again divided into sidals, bactericidals, bacteriostatic. So, organism will be stopped here, killed here, bactericidal and bacteriostatic standard drugs, and reserved drugs used for multi-drug resistant tuberculosis. Okay, these are called reserved drugs, and these are normally given standard drugs. Okay, first line. Okay, and these are again bactericidal, bacteriostatic. So, this is another classification that first line, apart from this first line drugs and second line drugs, these are standard drugs and reserved drugs. Okay. So, what are the examples? Bactericidal, isoniazid, isoniazid, rifampicin, streptomycin, pyrazinamide. Okay. Isoniazid acid, rifampicin, streptomycin, pyrazinamide. These are bactericidal. So, there will be a chance of asking like what of the following is a bactericidal drug, bacteriostatic drug. Okay. So, ethambutol and thiazidone are bacteriostatic. And reserved drugs, coming to the reserved drugs, capreomycin, kanamycin, fluoroquinolones, okay, these are bactericidal, and bacteriostatic are ethionamide, cycloserine, paramino, salicylic acid. So, we have seen two kinds of classifications, first line drug classification, second line drug classification. First line drugs are RIPES and second line drugs are PEC, okay. Yeah, RIPES are first line, second line are PEC and fluoxetines, okay. And then standard drugs, reserved drugs. Standard drugs are bactericidal, bacteriostatic, reserved drugs bactericidal and bacteriostatic. So, this is the two kinds of classifications under anti-tubercular drugs. Now, we will see the mechanism of action. First, you have to know what is the, how many layers or what is the site of actions of the anti-tubercular drugs. That means you have to know about the cell wall layer of this bacterium, okay, mycobacterium. So, if you see, mycobacterium is having different layers. So, first layer is plasma membrane. So, this is a plasma membrane is a layer. After that, there will be a peptidoglycan layer. Peptidoglycan layer consists of N-acetyl glycosylamine and glycoyl muramic acid, okay. So, these two are connected by 1,4 linkage, and also peptide chain will be there. Peptide chain consisting of D-alanine, D-ala, D-glue and mesodiamino pimelic acid and DLA, okay. So, there will be a first layer is this thing, okay. So, I am discussing about the cell wall of mycobacterium, okay. So, there will be first layer plasma membrane, okay. And then there will be a thick peptidoglycan layer, okay. This consists of this is a peptide chain, okay, and muramic acid and acetyl glycolic muramic acid glycosylamine. These are linked by 1,4 linkage and peptide chain. This whole thing is peptidoglycan layer. Thick peptidoglycan layer will be there, which is the main protective or the important part of this mycobacterium cell wall, okay. And then there will be a AG layer, that is called arabinogalacton layer. This arabinogalacton layer at the terminal ends consists of mycolic acids, okay. These are mycolic acids. This is the main site of action, because most of the drugs will target this mycolic acids. This is the mycolic acid, okay. Mycolic acid. So, mycolic acids, if you see, terminal mycolic acid residues are present at the arabinogalacton layer. Thus, this terminal mycolic acid residues which are site of action for most of the anti-tubercular drugs. Why? Because if these are targeted, mycolic acid synthesis is prevented. Mycolic acid synthesis is the main base for the cell wall synthesis. If cell wall synthesis is inhibited, then the mycobacterium cannot survive. So, this is the funda. And then other layer is this one. This is also targeted lipoarabinomannan layer. This is LAM layer. So, this is the cell envelope of mycobacterium, okay. This mycobacterium consists of plasma membrane, above that peptidoglycan layer. Peptidoglycan layer is a thick peptidoglycan layer, consists of N-acetyl muramic acid, N-acetyl glucosamine connected by 1,4 linkage, and above that this N-acetyl glycosamine and glycoyl muramic acids are connected by, okay, peptide D-alanine D-glutamine, okay. So, this peptide chain, okay. This whole thing is peptidoglycan layer. Above that is a AG layer, arabinogalacton layer. arabinine galactane layer about the residues, the terminal residues are mycolic acids. Above that is lamb layer. Okay. So, this is the cell wall, because I am stressing here why, because the whatever the drugs we are getting will target these parts. So, we will see how they are targeting. So, first drug is isoniazid. So, isoniazid is the first line drug. Okay. Now, so this slide will give you the whole information about isoniazid. First, you see the structure here. So, this is a pyridine. This one is, this is called pyridine. Okay. Pyridine 1, 2, 3, 4 carbohydrazide. Pyridine carbohydrazide. This is the IUPAC name, and mechanism of action is, this is a prodrug. Which of the following is a prodrug? So, if in this topic you will get some prodrugs which are activated and gives the active metabolites. Okay, so this isoniazid is also a prodrug, and this is activated through a oxidation reaction. Which reaction? Oxidation reaction. This is also important point. Okay, this is activated by oxidation reaction, and it is catalyzed by enzyme 𝐾𝐧. Okay, and thus this prodrug is converted into active metabolite and inhibits the long fatty chain acid synthesis. That means it inhibits the mycolic acids. Fatty chain acids are mycolic acids. So, mechanism of action is inhibiting the mycolic acid residues. Okay, and it is a prodrug. It is activated through what reaction? Oxidation reaction, and this happens in presence of 𝐾𝐧 enzyme. And then see, there are two nitrogens here. Okay, so any substitution on this nitrogen will give you active compounds, but substitution on this nitrogen will give you inactive compounds. Okay, substitution here inactive compounds, substitution here active compounds. This is the important point in SIR. And drug interactions, this is the important point. Aluminum containing antacids can interfere with or delay the absorption, therefore it is recommended to be taken on empty stomach. So, isoniazid is recommended to be taken on empty stomach. So, important, you just list out the drugs which are recommended by taking on the empty stomach. Okay, because the questioning will be asked in such a way that which of the following drug is recommended to be taken on empty stomach. Since this is a pharmacist examination, so a pharmacist should have a minimum concept of about the drugs, which drug have to be taken on which way. Okay, so this is one such point. Isoniazid is recommended to be taken on an empty stomach. Why? Because aluminum containing antacids can interfere with, or its absorption is delayed. Okay, and hepatotoxicity is the important adverse effect. This is all about isoniazid. Okay, let's move into the next drug is pyrazinamide. Pyrazine, this is pyrazine, and you have amide. Okay, pyrazine 2-carboxamide. Pyrazine 2-carboxamide, 1,2-carboxamide. Okay, pyrazine 2-carboxamide, that is pyrazinamide, and this is a bioisoster of nicotinamide. So, pyrazinamide is a analog of nicotinamide. Okay, and another important point is it is inactive at neutral pH. It is active at acidic pH. At neutral pH, it is inactive. Okay. So, what is the mechanism of action of this drug? So, isoniazid is targeting the mycolic acid synthesis. Here, susceptible organisms produce pyrazinamidase, which is responsible for conversion of pyrazamide to pyrazinic acid. So, this is converted into pyrazinoic acid. Okay, in presence of enzyme pyrazinamidase. Okay, what is the enzyme? Pyrazinamidase. Pyrazinamide is converted into pyrazinoic acid. Okay, since this is an acid, what it will do? See, this pyrazinamidase is produced by the organism itself. Then it is converted into pyrazinic acid. It causes the acidic pH. See, it lowers the pH in the immediate surroundings. So, the bacterial surroundings pH is reduced. Since this is an acid, its acidity, okay, the pH around the organism is reduced and it is acidic nature, and therefore, the organism cannot sustain or it cannot grow. Okay. So, this is the mechanism of action. So, this is what is the important point here? This is a nicotinamide analog. okay, and it is inactive at neutral pH. It will convert into acidic pH by conversion of pyrazinamide into pyrazinoic acid in presence of pyrazinamidase. This acidic pH will stop the survival of the bacteria, thus the bacteria will die. Okay, and one important point is substitution on pyrazine ring. Any substitution on this pyrazine ring will reduce the activity. There should not be any substitution on this pyrazine ring. Another important point is this pyrazinamide is not affected by the presence of food in the GI tract or by the use of aluminum containing antacids. So, there is it is not required to be taken on empty stomach because this is not affected by the antacids, which is opposite to the isoniazid drug. So, these are the important points about pyrazinamide. Let us see the next drug, ethambutol. Ethambutol hydrochloride, that is, this is the ethambutol. Ethylene is there, ethylene diiminobutanol. Ethylene, okay, ethylene diiminobutanol, okay. 1, 2, 3, 4, 1, 2, 3, 4, okay, 4 carbon is there, butanol. So, 2 hydroxy groups are there. Ethylene diiminobutanol. One important point here is plus enantiomer is 200 to 500 times more active than minus enantiomer. Okay, which of the enantiomer is more active? Plus enantiomer of ethambutol is more active, and this is a water soluble drug. Okay, so you have to list out the water soluble drugs, lipid soluble drugs. Why? Because this absorption, metabolism, ADME properties of the drugs are very important from the exam point of view. Okay, so which of the following is a water soluble drug, which of the following is a lipid soluble drug? That kind of questions will also be asked. So, ethambutol is a water soluble drug, and mechanism of action is mycobacterial cell wall synthesis. So, I will give you the list of all the drugs which are acting at what point, site of action. So, here ethambutol is targeting the cell wall synthesis. Then how it is targeting? It inhibits the incorporation of mycolic acids. That is why I am telling mycolic acids are very important from the site of action point of view of the antitubercular drugs. Most of the drugs will inhibit the cell wall synthesis by targeting this mycolic acids only, and inhibits the enzyme arabinosyl transferase, which catalyzes the formation of arabinosyl galactine layer. Okay, so main site of main action is inhibiting the cell wall synthesis by inhibiting the mycolic acids incorporation. Okay, and which enantiomer is more active? Plus enantiomer is more active, and this is the water soluble drug. These are the important points. See, for each and every drug, which point of view I am giving the information here. Okay. Now, which of the following is an antibiotic antitubercular drug? Okay. So, whatever the drugs we have discussed till now, all the 3 drugs are not antibiotics. Whatever the drug we are now going to discuss, that is rifamycin, that is a antibiotic. Okay. So, one important point and the previously asked question is, rifamycin belongs to which class of natural products? Okay, that is anasmycin. Rifamycin belongs to ansamycin class of, okay, anasmycin class of drug. Okay, so this is the natural one produced by Streptomyces mediterraneae. Here also you have to make a chart which is the causative organism for the antibiotic. Productive organism. That means the which antibiotic is generated or produced from which microorganism. Here rifamycin is produced from Streptomyces mediterraneae. Okay, and this belongs to anasmycin. What is anasmycin? Anasmycin class of drugs are nothing but it's a rigid structure made up of 2 aromatic rings connected by long chain. So, there will be a long aliphatic chain and 2 aromatic rings in their structure connected by a long rigid aliphatic chain. So, this is anasmycin structure. Okay. So, here rifamycin belongs to this anasmycin class of drugs. And what is the mechanism of action? Inhibits DDRP. What is DDRP? DNA dependent RNA polymerase enzyme. Thus, it is inhibiting the RNA synthesis. So, its action is completely different. okay, right, not it is targeting the cell wall synthesis or protein synthesis of the bacterium, it is targeting the DNA dependent RNA polymerase enzyme of the bacteria, okay. And in its structure naphthalene ring will be there. I will show you the structure, but important ring in the rifamycin or antibiotic is naphthalene ring, okay. Naphthalene is the moiety present in the structure of rifamycin, okay. It forms pi-pi bonds with the aromatic amino. So, this forms the pi-pi bonds with DNA dependent RNA polymerase. So, this is the drug, this is the targetive protein, and these two are linked by pi-pi bonds. This is the way how the rifamycin is showing its activity, or this is binding to DDRP by pi-pi bonds, and thus it is inhibiting this protein, okay. And some important point, only one important point here is because it productive organism. Rifamycin is produced from Streptomyces mediterranae and belongs to Anasmycin class. Next, so this is the natural one, what we have discussed earlier, rifamycin is a natural one, and from that some semi-synthetic derivatives are also prepared. Semi-synthetic derivatives are what? Rifampin. So, short form RIF will be mentioned in the next slides also. Rifampin, rifapentin are semi-synthetic derivatives. So, you will be given the question like this: rifabutine, rifapentin, rifampin, rifamycin, which is the natural one. Okay, all the four, rifampin, rifapentin, rifabutine are semi-synthetic derivatives. Rifamycin is the natural derivative, okay. Because of the, see here, because of the poor penetration of cell wall of gram-negative organisms by rifampin, drug is very less effective, okay. Natural one is a more effective one. And metabolism, it is metabolized, or it is a potent inducer. So, CYP inducers, CYP inhibitors. Here, rifampin is a potent inducer of CYP3A4 enzyme, okay, potent inducer of CYP3A4 enzyme, okay. It decreases the effectiveness of the oral contraceptive. So, since it is an inducer of CYP3A4, whatever the substrates of CYP3A4 are there, all the levels will be decreased. So, all these drugs like oral contraceptives, corticosteroids, warfarin, quinidine, methadone, zidovudine, clarithromycin, azole containing antifungal agents, all these are the substrates for CYP3A4, okay. That means these drugs will get metabolized by CYP3A4 enzyme. If CYP3A4 is more activated, more induced, then its activity is more, and whatever the drugs, all these drugs, oral contraceptives, corticosteroids, all these drugs you have to keep in mind, because these drugs when taken in combination with rifampin. So, rifampin plus either oral contraceptives or steroids, corticosteroids, warfarin, okay. Any of these drugs combination should not be taken. Why? Because their levels will be decreased because of rifampin, okay. Rifampin will decreases the levels of these drugs, okay. Their activity will not be shown much. Why? Because it is a inducer of CYP3A4 enzyme, okay. Very, very important point to be noted here. Next is so if you see here, this is the structure of rifamycin. Rifamycin, I have already said there will be a naphthalene ring, okay. Naphthalene ring is there in the structure, okay. And then free OH groups are there, right. These OH groups, whatever the free OH groups are there, the OH positions are what? C1, C8, C21, C23, 18, 21, 23. OH groups should be there. And acetylation at C21, C23 produces very, very inactive compounds, okay, very, very inactive compounds at C21, C23. So, C21, yeah, C21, C23, C1, 8, 21, 23, free OH groups should be there. If any of these groups are getting acetylation, then it will reduce the activity. It will increase the activity, free OH groups are there, okay. And if you see, this is the macro ring, this is the macro ring, double bonds are there, see, double bonds are there. So, reduction of the double bonds or opening of the macro ring will cause inactive compounds. Okay, these are the 3 important points. Position of free OH groups are C1, C8, C21, C23. Acetylation will reduce the activity, and also reduction of the double bonds or opening of this macro ring. This is the ring. This is the macro ring. If the ring is get opened or this double bonds are reduced, that will reduce the activity. And these are the 3 important points about rifamycin. Okay, so important points: what are natural antibiotics and what are semi-synthetic antibiotics, that you have to make a note. And metabolism, it is can be rifampin absorption can be reduced by food in the intestine, therefore the drug should be taken on empty stomach. Okay, so now what are the drugs we have come across? Isoniazid is taken on empty stomach, and rifampin is also taken on empty stomach. The major metabolism of rifampin is deacetylation. Okay, what is some important reactions also you have to keep in mind. So, how the prodrug isoniazid is getting activated? By means of oxidation. How the drug rifampin is getting metabolized? By deacetylation. That also gives rise to active compounds. Okay, deacetyl, desacetyl, rifampin, desacetyl, rifapentin. Okay, these are the metabolites which are active. Okay, some metabolites are active as like the drug also, some metabolites are inactive. In this case rifampin, the active metabolites are also active: desacetyl rifampin, desacetyl rifapentin. Okay, these are the important points. Now if you see rifabutin, okay, rifampin, rifabutin, rifapentin are semi-synthetic derivatives. So rifabutin, what is the derivative here? Rifabutin, spiroimidazopyridyl derivative. Okay, spiroimidazopyridyl derivative. So whatever the doubts you are getting, you can just ping me and I will clarify your doubts at the end of the session. Okay, rifabutin is a spiroimidazopyridyl derivative of rifamycin B. See, this is a lipophilic compound. So I have mentioned earlier also, you have to make a note of whatever the water soluble drugs, what are the lipophilic drugs, okay, lipid soluble drugs. So in this case here rifabutin is lipophilic compound. Rifabutin and its metabolites are highly colored compounds that can discolor the skin, urine, tears, feces. All the body fluids will get colored by this drug rifabutin. Okay. Next, HIV protease inhibitors and are inhibitors of CYP3A4. Okay, see here rifabutin plus HIV protease inhibitor drugs, HIV protease inhibitor drugs. This combination should not be given. Okay, because a combination of rifabutin plus HIV protease inhibitors is expected to increase the, so rifabutin concentration is increased and it will give rise to toxicity. Okay, side effects. The side effects of the rifabutin will be increased when you take the drug combination HIV protease plus rifabutin. Okay, the aim of the pharmacist is to not just to dispense the given prescription drugs. Okay, the pharmacist should have an idea about the drug interactions. Okay, which drug has to be taken at what time, which drug should not be taken with the what drug. Okay, so drug interactions is one of the very important concept for the pharmacist. Okay, for the awareness of the pharmacist. So these are some of the drugs. These are, since anti-TB drugs are a very important concept, whatever the drugs which has to be taken with, which has not to be taken with, has to be mentioned. So rifabutin should not be taken with HIV protease inhibitors. So question will be asked like this: which of the following drug should not be taken along with HIV protease inhibitors, or rifabutin should not be taken along with which of the following drugs? So 4 options will be asked. So combination of rifabutin and HIV protease inhibitors is a deadly combination, should not be taken. Why? Because the side effects of rifabutin will be increased. Next, most serious effect. What is the side effect of this rifabutin? Uveitis. Uveitis is the inflammation of iris. Okay, uveitis is the inflammation of iris. This is caused by rifabutin. So rifabutin, if you take along with HIV protease inhibitors, its side effects are elevated. These are the important points about rifamycin. Next we will see rifapentin. Rifampicin is the first new agent introduced for the treatment of pulmonary TB. Pulmonary TB, semi-synthetic antibiotic. Semi-synthetic antibiotic belonging to anasmycin class. This is rifampicin and first new agent. Okay. So, semi-synthetic antibiotic anasmycin classes, so many drugs are there. Rifabutin, rifampin are also there. What is the speciality of rifampicin? Rifampicin is a new agent introduced for treatment of pulmonary TB. And see here, which of the following drugs will cause discoloration of the body fluids? All the semi-synthetic drugs. Rifampin, rifampicin, rifabutin. All these three drugs will cause discoloration of the body fluids. An important point to be mentioned. Why? Because after dispensing the rifamycin drug, if the patient is complaining about the discoloration of the urine or tears or any of the body fluids, then the pharmacist should have an idea that it is not a panic kind of thing. So, this is a common thing with the semi-synthetic drugs. Rifampin, rifampicin, rifabutin is a common thing which causes the discoloration of the body fluids. Next is streptomycin. Streptomycin is the aminoglycoside antibiotic produced by Streptomyces graeseus. Streptomyces graeseus. This is a aminoglycoside antibiotic. Aminoglycoside antibiotic, and this is also water soluble. Okay. So, I have given you the list of water soluble drugs and lipid soluble drugs. Okay. Till now we have come across 2 water soluble drugs and 1 lipid soluble drug. Okay. And aminoglycoside, so it is obviously basic in nature. It is available as the trihydrochloride or sesquisulfate salt and inhibits the protein synthesis. Mechanism of action of aminoglycoside antibiotic is streptomycin is inhibiting the protein synthesis. See, this is the structure of streptomycin. Okay, I am not going much deeper into this structure. So, here our concept of antitubercular agents is the chemistry wise, okay, not ecology wise. Okay, this is the chemistry point of view we are discussing. That is why here a small point about the SAR. Okay, see, if you observe here, there is a aldehyde group. Reduction of aldehyde to alcohol gives dihydrostreptomycin that have activity similar to streptomycin but deafness. What is the side effect of this streptomycin? Severe deafness. Okay, that is caused whenever this aldehyde is reduced to alcohol. That is resulting in the formation of dihydrostreptomycin. Okay, even though the reduction of aldehyde to alcohol is causing, the deafness is the side effect present in both streptomycin as well as dihydrostreptomycin. Next drug is ethionamide, very simple drug. Mechanism of action is inhibitory effect of mycolic acid synthesis. Okay, so this is the ethionamide. If you see, pyridine structure is there, okay, and ethyl is there. 1, 2, 3, 4, 5, 6. Second position ethyl, 2 ethyl pyridine 4, carbothioamide. This is thio, okay, amide, carbothioamide, ethionamide, carbothioamide, ethionamide. Okay, this is a pyridine analog. Okay, and this is also a prodrug converted into an active acylating agent, ethionamide sulfoxide. This is also given as prodrug. Okay. So, this is an important point about ethionamide. Next we will see this para-amino salicylic acid. Para-amino salicylic acid. This is the antimetabolite. Which of the following anti-tubercular drug is an antimetabolite? That is para-amino salicylic acid. Why it is antimetabolite? Because it is targeting the precursors, DNA formation. It is targeting the formation of the DNA and RNA precursors. Okay, it interferes with the incorporation of PABA, which is a precursor, into folic acid. So, folic acid synthesis is inhibited. This is the precursor of DNA and RNA synthesis, which is prevented in the mycobacterium. Okay, that's why this is the antimetabolite, para-amino salicylic acid. And gastric irritation, hypersensitive reactions are the important side effects, and its biological activities is about 2 hours. Okay, this is para-amino salicylic acid. This is the structure of para-amino salicylic acid. See, this is a carboxylic acid, this is amino, both at para positions. 4 amino, okay, 1, 2, 3, 4, 5, 6, 4 amino, 2 hydroxy benzoic acid, that is para-amino salicylic acid. Which of the following drug is antimetabolite, anti-TB drug, antimetabolite, anti-TB drug, that is para-amino salicylic acid. So, this is a very well known synthesis, only one synthesis of para-amino salicylic acid I have included, other synthesis also are there. One important synthesis is nitration, okay, nitration of anthranic acid. Starting point is anthranic acid, you will go for nitration. So, nitration, nitro group will be there, and then this NH2 group will be converted into OH and reduction, followed by reduction, nitro reduction in presence of tin HCl, amino group will be formed. So, starting material is what? Anthranic acid. Nitration of anthranic acid followed by reduction will give you para-amino salicylic acid. Next drug is cycloserine. Cycloserine, each drug, each slide, okay. Maximum amount of information has been included, its mechanism of action, structure, okay, and important side effects. So, cycloserine we will see it is also called as seromycin. See, what is the important point here? This is an analog of D-alanine, okay. So, if you remember, D-alanine is an important peptide chain linked to the N-acetylmuramic acid, N-acetylglycosylamine in the peptidoglycan layer. So, peptidoglycan layer is a very important layer for the cell wall of the important cell wall component of the mycobacterium. So, peptidoglycan layer consists of peptide chains of D-alanine. So, D-alanine structure is very much similar or analog of this cycloserine. This cycloserine is the analog of the same D-alanine. If you see both structures are same, cyclo formation will be there. So, question will be asked like this: cycloserine is an analog of which of the following amino acid? Which of the following amino acid? Cycloserine is the analog of D-alanine. D-alanine is an important component in bacterial cell wall. So, cycloserine is a natural product obtained from Streptomyces orchidaceus. So, this is almost third drug which is obtained from the natural sources. Okay. Rifampicin, aminoglycoside antibiotic, streptomycin, and now this is cycloserine. Cycloserine is obtained from Streptomyces orchidaceus, and it is obtained as a D plus enantiomer. Now, since it is an analog of D-alanine, it inhibits, competitive inhibition will be there by inhibits the binding of D-alanine to D-alanine racemase and D-alanine ligase, which are useful for the incorporation of peptidoglycan, and D-alanine is important part of mycobacterium cell wall. Now, I will show you, see the mechanism of action will be like this. This is a D-alanine, I already said, L-alanine is converted into D-alanine in presence of D-alanine racemase. D-alanine will combine with another D-alanine in presence of D-alanine ligase. So, this conversion will be stopped by cycloserine. This conversion will be stopped by cycloserine because D-alanine, D-alanine, chains will be formed. These are important for the peptidoglycan layer formation. Peptidoglycan layer is important for bacterial cell wall. So, if this cycloserine is targeting this L-alanine to D-alanine conversion, thereby preventing the D-alanine formation, thereby preventing the peptidoglycan layer. Okay. This is the mechanism of action of cycloserine. Next drug is capreomycin. Capreomycin is also called as capostat. Okay. This is a polypeptide which is a cyclic polypeptide. Which of the following drug is a cyclopeptide? Okay. Cyclic polypeptide. 4 cyclic polypeptides will be there. Okay, capreomycin 1A means R is equal to OH, capreomycin 1B means R is equal to H. Since it is a polypeptide, there is no need of remembering this whole structure, only R group you can remember. Okay, 1A R is OH, 1B is RH. It produced by Streptomyces capreolus, Streptomyces capreolus. Okay, and it is targeting the protein synthesis. What is the important side effect? Already previously asked a question. Damages the 8th cranial nerve. Okay, important side effect of capreomycin is damage to the 8th cranial nerve and renal damage. Okay, this is the important points about capreomycin. Mechanism of action is protein synthesis inhibitor produced by Streptomyces capreolus. You can easily identify the by species name, and it is a polypeptide. Which of the following drug is a polypeptide? Okay, that is a capreomycin, and it damages the 8th cranial nerve. Kanamycin, only important points is kanamycin A R is equal to OH, kanamycin B R is equal to NH2. This is also aminoglycoside class of drug. Next is other fluoroquinolines, some fluoroquinolines what we have studied, floxacins, floxacin, moxifloxacin, levofloxacin. See, levoisomer of floxacin is called levofloxacin. Okay, levoisomer of floxacin is levofloxacin. Only important point here is mechanism of action. Okay, all these floxacins binds to the DNA gyrase DNA complex enzyme. Okay, so it inhibits the bacterial DNA replication and transcription. Next are macrolide antibiotics. Two examples are there, clarithromycin and azithromycin. Clarithromycin, azithromycin, macrolide antibiotics. So these are considered to be the first line agents for the prevention treatment of Mycobacterium avium complex. Okay, the macrolide antibiotics are the agents that inhibits the protein synthesis by binding to 50S ribosomal units. 50S ribosomal units. Okay, so macrolide antibiotics are protein synthesis inhibitors, but by binding to the 50S ribosome units. Clarithromycin is an inhibitor of CYP3A4. Inhibitor of CYP3A4. There, if inducer, potent inducer of CYP3A4, clarithromycin is an inhibitor of CYP3A4, which could lead to the increased concentrations of other drugs like rifabutin. Okay, so these are the important drug-drug interactions. Now we will see what is the site of action of, we have covered all the drugs what we have mentioned, their mechanism of actions, important adverse effects, their structures, okay, and site of actions. Now we will see overall where the cycloserine, see, if you see, cycloserine is a drug which is acting on peptidoglycan layer. So the following layer, which of the following drug is acting on peptidoglycan layer? Cycloserine. And ethambutol is one drug. See, this arabinosyl transferase is an enzyme which is useful for the formation of arabin and galactan layer. Arabinosyl transferase. This is an enzyme responsible for the formation of arabin and galactan layer. So this enzyme is inhibited by ethambutol. So if we talk much deeper what is the mechanism of action, it is inhibiting arabinosyl transferase enzyme. Okay, and then isoniazid and ethionamide act on mycolic acid residues. So which of the following drugs are acting on which of the following pair of drugs, okay, are acting on mycolic acid residues. The question will be asked like the pair of drugs acting on mycolic acid residues, that those are isoniazid and ethionamide. Okay. Now I will give you a gist of all the drugs and their site of actions. So isoniazid and ethambutol, two drugs are acting on cell wall synthesis, inhibits the cell wall. Why? Especially acting on mycolic acids. Okay. Then pyrazinamide. Pyrazinamide is a drug that lowers the pH around around its surroundings, and therefore in the acidic conditions the drug bacterium will not be survived. So, pyrazinamide action is completely different. It is converted into pyrazinoic acid, and pyrazinoic acid will reduce the acidity in the surrounding areas of the bacterium, and thus the bacteria will not grow. But isoniazid and ethambutol are cell wall synthesis inhibitors. Rifamycin, DDRP, RNA synthesis, the DNA dependent RNA polymerase enzyme inhibitor, that is rifamycin. Aminoglycosides, streptomycin, macrolides, clarithromycin, azithromycin, cyclic peptides, capreomycin. These three set of drugs are protein synthesis inhibitors. Ethionamide, mycolic acid synthesis inhibitor. So, one way we can because by targeting mycolic acid, cell wall synthesis inhibition is inhibited in the isoniazid ethambutol. Ethionamide inhibits the synthesis of mycolic acids. Para-aminosalicylic acids interferes with the incorporation of, this is a antimetabolite, already we discussed, okay. This is an antimetabolite. Cycloserine acts on peptidoglycan layer cell wall synthesis inhibitor. This is also cell wall synthesis inhibitor by acting on peptidoglycan layer. By acting cell wall synthesis inhibitor by acting on mycolic acid residues. Cell wall synthesis inhibitor, okay, by acting on mycolic acid residues, ethionamide also. Levofloxacin is a DNA gyrase enzyme inhibitor. So, this is the overall different kinds of drugs, their structural classification and site of action. And one more small glance of these drugs, which of the set of drugs are cell wall synthesis inhibitors. Just now we discussed isoniazid, ethambutol and cycloserine. Which of the following drugs are protein synthesis inhibitors, that are aminoglycosides, okay, aminoglycoside drugs, and cyclic peptide. Which of the following cyclic peptide is a protein synthesis inhibitor drug? Protein synthesis inhibitors are so many are there, streptomycin, clarithromycin, azithromycin and capreomycin, but cyclic peptide drug is capreomycin, okay. TB prodrugs. So, isoniazid is given as prodrug, pyrazinamide is given as prodrug, ethionamide is given as a prodrug, okay. So, I will stop here. The next class we will see the overall questions, direct questions what have been asked from the anti-TB, and also we will see now the okay. Okay, in the next class we will continue from the synthesis point of view. Thank you.